Welcome back to 3+U. Of course, February is Heart Month, and we are trying really hard to get you all kinds of information that could actually save your life. And here with me is Dr. Robert Huang. He's a cardiologist with the Chattanooga Heart Institute at CHI Memorial. And Dr. Huang, let's start first of all. Thank you for being here. The heart, I'm 50 years old, so it's kind of one of those things that is on the front of my thinking when I'm thinking about my health. Is that correct? The more we age, is the heart something that can be a little more tricky, heart attacks, things of that nature?
So coronary artery disease or blockages in the heart due to cholesterol plaques are the number one killer, or still the number one disease in the United States today. So 510,000 people will have new heart attacks this year. So we try to minimize those risk factors. Keeping a proper weight, getting the proper diet and exercise are all very important for preventing this condition.
And doctor, how much is it genetics? How much is it lifestyle? I mean, are there some things that we just can't control?
So we know that genetics does play a role in this, but we also know that lifestyle plays a big role as well. So morbidly obese, diabetics, as we age, we're going to have more tendency to have coronary artery disease. So, but yes, family history is a very big portion of this as
Doctor,
well.
we have some great technology that we're going to talk about coming up that if someone does have a heart attack, they can get healed a little more healthy, a little more quicker. We'll talk about that in just a second. But first of all, let's talk prevention. What are some preventative things that people that are at risk can do? They need to start doing today. You just mentioned it. They're obese. Maybe they're smoking. What are some of those things?
So, again, I think watching your diet, making sure you're not eating too much processed foods, having a healthy diet full of fruits and vegetables, limiting your red meat consumption, all of those have been shown to help to prevent coronary disease. I think moderate activity for at least 30 minutes most days out of the week, those are what the guidelines tell us. So I think those are all very important for prevention.
So are there different kinds of heart attacks? I know there are small ones. There's the, quote, widowmaker that we hear about. Is it the same heart attack, just different levels, or are there different parts of the heart that can suffer?
So there are three main arteries, the right coronary, the LAD, which is commonly known as the widowmaker, and then the left circumflex artery. Any one of those three can go down, or you can have branches of those have clots in that, and that's what actually causes a heart attack. So, one of the most gratifying things we do is stop heart attacks.
Now, interventional cardiology, that's something that you specialize in. Tell me what interventional cardiology is.
So what we do is usually, cardiology is studying conditions of the heart. As an interventional cardiologist, we try to perform procedures that are less invasive. So whereas sometimes people will have multiple blockages and need bypass surgery through a traditional sternotomy where they cut open the chest, what we try to do is we usually go through an artery and we can put in stents to try to keep those arteries open if it's appropriate.
Now that is not. Okay, so help me keep this straight in my head. So somebody, and we're seeing video of it here, so I'm seeing all of the blockages there. I'm guessing that's calcified plaque or whatever that's building up on the arteries.
Yes.
So is that somebody that has had a heart attack, or is that somebody that is at risk? Who is the stent for? Somebody that's already had one, somebody that's at risk, or both?
So it's both, actually. The difference is in a heart attack, you have the cholesterol plaque that then basically it ruptures, and that causes a clot to form, and that clogs the artery from having blood flow through it. That's what causes the acute symptoms. So what we do is usually go in with a wire, get past that clot, and then balloon it open, and then put in that stent, just as you guys saw right there. So that's what they're showing right there. But you can also do it for when you have critical blockages. Sometimes those plaques don't necessarily rupture and cause a heart attack, but they are at risk. So by doing various testing first, stress testing, we can see whether those areas of the heart are not necessarily getting enough blood flow. And then what we do is we go ahead and go in and use coronary angiography take a look, shoot X-ray dye, and see if there are any blockages.
When do we get started thinking about this? I mean, because if I'm, again, I'm 50 years old, if I have some, calcium building up in my arteries, or cholesterol building up in my arteries, how will I know? Will I exhibit symptoms before a heart attack? Or
yeah, so sometimes the symptoms can be fairly subtle. Sometimes they're very acute and hit you right in the face. A lot of it are chest pain, squeezing, heavy pressure in the center of your chest that radiates into your jaw or into your neck, as well as into your left arm. That's kind of the classic symptoms that people have. Sometimes you can get stomach pain. Sometimes you can get shortness of breath, fatigue, lightheadedness, and dizziness.
Regular checkups with a doctor can detect this pretty easily, correct?
Sometimes the symptoms can be very subtle. Like I said, a lot of people say, hey, I'm not able to do what I used to do. I'm getting short of breath when I walk up a hill or up a grade. So,
but I guess what I'm asking more so is it something that when we go to get regular checkups at a certain age, the doctor will say, oh, you're 40, 45, 50 years old. Let's get your heart scanned also and make sure there's no buildup. Is that something that we need to request? Will a regular checkup, a general practitioner, recommend that to us?
Some of them do, or some of them will refer to a cardiologist. I think that's all based off of risk factors. So,
okay.
Again, like we were saying, family history, comorbid conditions such as diabetes, smoking, those types of things that will end up, getting someone to refer for a stress test and or referral to a specialist.
Now let's get back to the stent for a second. It used to be you put it in the groin and the thigh somewhere. Now we put it in the wrist. That's some of the latest stuff going on. Why do you put it in the wrist? What's the benefit?
Right. So we've been for probably the past 5 to 10 years we've moved it from going from the groin to the wrist, and most places now can go through the wrist. But the reason we did that was for patient comfort. Traditionally through the groin, you would have to lay still for a good 4 to 6 hours after the case. Now with radial artery catheterization, we just put a small band on after the procedure, and you're able to sit up right away and eat and basically leave the short stay area within probably 45 minutes to 2 hours. So
that's amazing. Well, doctor, thank you so much. Again, this is Heart Month, and as part of that, Dr. Huang coming on to the Chattanooga Heart Institute at CHI Memorial. Thank you so much. Great information, and I would encourage you. My dad spent a little bit of time there, had a great experience, by the way. 6 locations. Give them a call, 697-2000. Get your questions answered. Also, a lot of great information on the website, ChattanoogaHeart.com. We'll take a quick break. More 3+U right after this.